Welcome everyone to Health System Management video. So, what is health system management? If you look into it, it is an amalgamation of the primary care, the secondary care, and the tertiary care. What? So, in totality, the whole gamut of the health system it comprises of three layers: primary, secondary, and tertiary. Primary is all about attending to the basics of medical activities, to the first care activity that we look into in the form of community nurses. Now, that is what we're talking about: the dentist, the pharmacist, the optician, therapist, the mental health worker. No, what exactly is it? Is the primary care is the basic requirement of for the well-being of the society. The primary care will look into the health care about the basic requirement for the community. Next comes the hospitalizations, where it requires a further interventions of medical interventions which is required out there. This comprises of hospital, inpatient, day surgery, and outpatient clinic. Now we are talking about a little serious ailments in terms of medical emergencies are concerned. We are talking about fever, we're talking about illness, we are talking about stomach upset, we were talking about bariatric surgery, something to do with your ophthalmologies, as in the eye. If you are going to uh, remove certain organs which requires minor surgeries here and there, where it can be done in a day. That is where the day surgery comes around it, the hospitals. And then we require people who needs to be admitted, probably operation has to be carried out and proper precautions has to be taken, and probably thereafter the operation observation has to be made whether the patient is actually recovering on the right note. Then comes the tertiary care unit, is all about the specialty unit. Now, this is the specialist unit where require invasive surgeries, which might have certain implications, which have there might be increased chances of mortality in such cases. For example, a bypass surgery, for example, a kidney transplant, or any site of any kind of organ transplant per se. The specialty units will again have inpatient, outpatient, and rehabilitation center. The healthcare sectors we have already spoken around here. The primary care is about your first point of contact, typically the family physician or the dentist. The secondary care is episodic, as in a fever, as in certain pain or certain ailment that cannot be uh, treated by the general physician per se. So, episodic treatment of illness, typically in hospital, as in outpatient, inpatient, and daycare. Then comes the tertiary, is where the invasive surgeries are required, which has a probability of a higher mortality rate. Highly specialized care for complex conditions. The patient journey an important consideration. Patient typically start with the primary care for diagnosis and may be referred to a secondary or tertiary care depending on the diagnosis part of it, depending about the symptoms that the patient is displaying for further treatment. The journey can be cyclical, with patient returning from primary care for long-term care altogether. Obviously, yes, there's a trend of delivering more services in primary care settings for convenience and cost effectiveness. If probably that is the whole gamut of the activities of health system, to cut down the cost, to beat down the cost down. And that is the reason why more and more services are being included into the primary care settings. Boundaries between sectors are blurring, with some secondary care services moving to a primary care settings. Primary care cost much less than the secondary or tertiary care, leading to a pressure to develop primary care capacity and self-care thereby. Allow me to give you example. In primary care, let's say the family care have approximately 9,000 patients. The secondary is all about the acute hospital, which might have 200,000 population serving. And the tertiary care is approximately a city that comes around it. The regional cancer center, which has approximately 3.2 million population being served. Now, these are the audiences. So for every 9,000 patient or 9,000 population, you might have a primary care. For every 200,000, we can look for a nursing home or a secondary care system. And for tertiary things, where we are going for specialized or multi-specialty hospitals, which would be serving a larger population per se. So yes, if you want to go around it, as we decrease from self-care to primary care, to secondary care, to tertiary. What as we looking into it, we are increasing the cost, and as we move from tertiary care to secondary care to primary care, we are decreasing the cost. This is a classic example of what has exactly happened. Remember, only a few population require tertiary cares, only few percentage of the population would be requiring tertiary care or invasive surgery. So healthcare organization by care level, which serves 9,000 people, is for family practices or primary care staff, which is usually three full-time or a four part-time general practitioners. So in totality, we have seven staff in the premises at any point of time. Approximately three to four people would be there 24 hours or seven. So of which three are full-time, four are part-time. Practice nurses and healthcare assistant may collaborate with other primary care providers and secondary care providers for additional services. Services provided are standard medical consultation, the family planning, maternity care, child health surveillances, immunizations, decreasing screening, chronic disease management, mental health services, which we talk about counseling and therapies. The secondary care organization probably looking at 200,000 people, which is a larger gamut of population altogether, which might have a staff of 2,500 people, beds approximately 420 inpatient beds, admissions would be approximately 5,000 elective admissions in 365 days, or should I say 21,500 emergency admission per year, and day cases is approximately 18,000 per year. The outpatient visits are much more higher because you look at the number that we are figuring into it. It's 63,000 emergency department visit per year and 230,000 outpatient departments per year. So department might be surgery, anesthesia, child and women services, general medicines, and older people, or diagnostic and therapeutics, clinical therapies, and rehabilitation, as the case might be. A tertiary care system would look into a specialized hospital, like let's say a cancer center, which serves approximately a complete city, 3.2 million people. Specialization in a cancer center. We can have a cancer center, we can have a heart center, we can have a neurological center. So there can be number of specialty that can comes around it. We can have nephrology centers. So yes, we are talking about clinical services at the district level. Surgeries are all about accident, emergencies, trauma, orthopedic care, nose, throat, oral, intensive care. Children and women are maternity, gynecological. Medicine and older people are general medicine, dermatology, diabetics, hematology, oncology, and neurology. Diagnostic and therapeutics are radiology, pharmacologies, and pathology per se. Now, this is what the pattern of people with a diabetic, suffering from diabetes or sugar, blood sugar, should I say. Primary care, what they do, they talk about the general practitioner, GP, or practice nurse, community nurses, specialty nurse and facilitator, community dietitian, optometrist, and community postcard, as the case might be. From primary care, they are being referred to a specialist, let's say ophthalmologist, or a foot team, or vascular surgeon, renal physician, which might be the secondary cases of what care to be taken by the hospital diabetics team. They might be referred to a tertiary if things are getting from bad to worse. And this keeps on coming around here. The primary and the secondary, there is a constant exchange of information or reference of referring the papers as what kind of diagnosis that needs to be done. So yes, and the patient would be explicitly displaying the symptoms, explicitly giving you hints, giving you clues, or informing you about what kind of discomfort that he or she is facing altogether. Shift towards primary care management. Recent policy focuses on delivering routine diabetic care in a primary care settings. This involves more specialized workforce for the primary care workers. Hospital-based diabetic centers can play a pivotal role, or should I say, an important role in coordinating such complex cases per se. Importance of collaboration. There is a growing trend of healthcare professionals working across both primary and secondary care settings. Effective care requires recognition the strength of each sectors and patient department. Now, let us look into just a case study for a diabetics team altogether. What happens with the primary care and what happens with the hospital care? Let's say in primary care, continuity of care to the patient happens, where in hospital it is specialist care, such as children or pregnant women. In primary care, the knowledge of the patient and their family comorbidities are known. In second line, in the hospital, is the second line treatment with poor ordinates diabetics or poor diabetics control altogether, as the case might be. Then we have expertise in managing chronic condition, expert supports and training for all the staff as on one basis. Locality caring for people with diabetics, including practicing nurse, general physician, community, podiatrist, and dietitian. What happened with the primary care services are often delivered to the home by the patient. But in hospitals, specialized patient education for a critical mass of patients, including those with special needs, such as ethnic minority groups, and providing inputs from arranged discipline per se. So yes, from general physician or practicing consultant, what we are looking at, they are referring to the hospitals who might again come back to the general physician with their references. The hospital might go for a certain kind of test, let's say blood, let's say they are referring to a consultant or an X-ray perhaps, or a radiotherapy or follow-up consultation. Basically, this is what we are talking about here. Remember, PC is all about primary care, SC is all about secondary care, and TC out here will be all your tertiary care, as the case might be. Look how the patient has been moved from one department to another department just to go for the diagnosis part of it, so that proper care and proper medicine can be imparted. So, general practitioners are part of your primary cares, refers hospital to an X-ray. Now, just giving a redesigning altogether for an ovarian cancer, the hospital sees a consultant, the operation, it goes back to the tertiary cares as in radiotherapy, comes with the secondary cares as follow-up consultation, and probably handed over to the primary care centers altogether. So, the healthcare ownership and the control models. There are four models. Remember, just four models: commercial, for profit organization, independent, and not for profit organization. And then we have the public owned organization, usually funded by the government, and the public owned and government controlled, completely under the ambit of the government, is what we are looking into it. Yes, so we have commercial, we have independent, not for profit, public owned, but funded by a government at certain point of time, and public owned and totally funded by the government. So that is what we are looking into it. Let us speak about the US healthcare system. The funding is all about mix, be it private and be it government insurances. Delivery, all four ownership models are used, but independent, not for profit is most common for hospitals. Government plays a significant role in shaping policies, funding, regulation, and despite being portrayed as a primary private. The UK National Health Services model is all about funding, generally done for all tax money, delivered dominated by the government funding because it is done by exclusively by tax money. Provisional for universal coverage for citizens, limited use of private healthcare providers. Recent trends include more independent publicly owned providers, increased use of independent for profit providers for specific services. Now let us look at for-profit healthcare organization in USA. Ownership, investor-owned commercial companies, be it public or private, accountable to shareholders. Goals: make profit for shareholders. Obviously, yes, increasing efficiencies and reducing cost, focusing on the profitability areas. Concerns are overemphasis on profit and probably not taking due care of the patients. So basically, the quality of services, the quality of care actually goes down, and the community needs are often overlooked. Counter arguments are high quality care leads to a satisfied patients and market share growth. Efficiencies and effectiveness are necessary for growth and prosperity. Probably that is what people would be looking into is for profit health organizations, for specialty hospitals that we are looking around here. Let us look at non-profit healthcare organization in USA. The ownership absolutely not owned by shareholders. Any surplus invested back into the company or back into the organization. Origins is all about charity, all about philanthropic concerns. Often church affiliated or probably university affiliated. Funded is operating surplus, borrowing from commercial lenders, and donations and fundraising. Example: Kaiser Permanente. That is what we are talking talking about integrated healthcare system. Now let us go to the National Health Service Trust, established 1991 in United Kingdom, completely owned and controlled by the Department of Health. Remember, Department of Health is a government entity. Accountability to the Secretary of the State for Health, governed by the Board of Directors, performance management managed by the regional board as a strategic health authority, financed by local purchasing bodies as in PCTs, primary care trust, viewed as a lacking autonomy from central government. The trust, Foundation Trust, established in 2004, is basically nothing but it's independent entities, but within the ambit of NHS, publicly owned but outside the central government control, considered public benefit corporations, controlled by members, local people, local staff, governed by elected board of governors, intended to have closer link with local stakeholders, accountable to regulator, or should I say monitor, instead of the secretary of the state. So we have a regulators basis, financed similarly to the NHS, the National Health Services Trust, seen as an offering for greater local ownership and control. Now let us understand which is good, public or private healthcare system. So public advantages are lower cost, definitely yes, particularly the administrative cost, more committed to quality improvement policies, easier coordination of societal goals. Disadvantages less flexible and innovative, may develop complacencies due to monopolistic position, bureaucratic and slow to adapt to new technologies, and potential for underinvestment. Now let us talk about the private healthcare system. The advantages is nimble, it is quick to meet the market demand, adopts innovations immediately, economies of skills and ability to work across region, invest in latest technologies to gain market share, integrated service provision, primary healthcare, secondary healthcare, tertiary healthcare for competitive advantages. The disadvantages of the profit organization, or should I say private organization. Profit maximization is what is the fundamental drive to lead higher cost and poor quality care. Less focused on clinician training, research, and community ties. Cream skimming of patients, avoiding complex cases. Difficulty achieving societal goals, reducing health equalities due to profit motives, as the case might be. The ownership and control trends. Healthcare systems are moving away from direct government control and public sector delivery. Services are delivered by a wide range of organizations. The public sectors is all about NHS, our foundation trust. The private sectors is all about for-profit and non-profit organization. Accountability is increasingly day by day achieved through contacts and regulation. Remember, contracts specifies everything out there what is expected. Debate continues about the ideal ownership model, public versus private, and not for profit, as the case might be. So, to conclude, there's no single model exists on a healthcare delivery system. There are competing paradoxical drivers and constraints within the healthcare system. Ownership model can have both positive and negative impact. Careful evaluation is needed to determine the effectiveness of the healthcare. With this, I come to an end of this presentation. Thank you for watching this video till the end.